The urinary bladder potentially has very different types of responses, or it's
Hmm.
evolved to use these responses in different ways because it's a different organ. It's an exit organ. So the immune response there has to kind of balance all these different things.
Before we jump into immunotherapy itself, can you give us a description of how the immune system responds to a UTI?
Yeah, so it's interesting, particularly in the urinary bladder. So of course, a urinary tract infection is an infection by bacteria of any part of the urinary tract, which is the urethra, the urinary bladder, the ureters, which is the tube that connects the bladder to the kidneys,
Hmm.
and of course the kidneys. The kidneys being the filtration device, it comes through the ureter to the bladder for excretion through the urethra. So it can be an infection in any part of that tissue. Now, it behaves a little bit differently depending on where it is in that urinary tract. But for the urinary bladder, it's a bit of a bizarre site compared to the kidney. So what
Hmm.
happens in the urinary bladder? We get this very good initial immune response, sort of the first responders, the cavalry comes in. It's called the innate immune response. And these have cells in their kind of white blood cells or immune cells called neutrophils and macrophages. And their job is to behave like little Pac-Man. They sort of come in and they sort of eat up the bacteria. And as part of that, you also get in the epithelium, as we talked about before, shedding into the urine. And of
Hmm.
course, because the bladder is an excretory organ, you can excrete through the
Hmm.
urine. So we can get rid of some of the bacteria through that process. So that works really well. What the bladder doesn't do well is develop what we call immune memory. So, if we think about vaccination, for example, we have a vaccine so that our immune system can recognize the pathogen where we get infected with it. So, that might be influenza when we get the flu jab, or it might be COVID when we get our latest COVID booster.
Hmm.
However, for bacteria that cause infection in the bladder, the immune system doesn't seem to really do that. And I think part of that might be that it's favoring repairing that bladder wall over a really effective immune response long term.
Hmm.
And the reason, and if you think about it, it makes evolutionary sense because the bladder is full of urine. Urine is highly toxic. You don't want that urine coming back through the
Hmm.
wall and causing damage. That could, cause some really serious issues. So evolutionary, we had to sort of decide on what's the better of the two evils. And
Yeah.
obviously, we've evolved to decide, well, we really don't want those toxins coming back in all the time. So we have to preference repair over antibacterial immunity. So we still deal with the infection, but we don't deal with it when we have recurrent infections. Now, when the infection gets to the kidney, it's a different story in the kidney. The kidney's
Hmm.
decided, okay, we're not a barrier site. We are basically the inside of the castle. We're the king and queen hidden up at the top tower. We're really important, and we can't have anything here. This is bad. If it gets
Okay.
here, it's going to get into our bloodstream. So now the immune system's decided, okay, in this organ, we have to do something about it. So now it develops a memory response. So next time you get an infection in the kidney, it knows what to do. And so for those people that have had really serious infections that get to their kidney, when they have a subsequent infection of the bladder, they're more likely to be able to clear it. But
Yeah.
for the people that have these infections that just keep happening in the bladder,
Hmm.
for whatever reason, our immune system doesn't generate that memory. So when we see it again, and patients, as you know, they get infected with exactly the same strain of bacteria. So something they've seen before.
Yeah.
And our immune system just doesn't recognize it, which doesn't make sense when we think about all
Yeah.
these other things we can be vaccinated against. So that's something we need to understand. We need to understand, why is that not happening? Is that different between males and females? Is that a reason why females are more susceptible to these infections, these recurrent infections? And then how do we manipulate that part of the host response for new treatments? And of course, that is immunotherapy, which I think is
Hmm.
your next question.
There was one sub question about the epithelial cell shedding. Is there any
Mhm.
visible evidence of this in the urine? Can you actually see the tissue or anything, or is that microscopic only?
It could be. You could have like clusters of them. So you
Hmm.
might see, some float around your urine, but you wouldn't be able to tell what they are. Will you
Yeah.
see something? Yes, probably. Can you say that that is actually epithelial cells? You'd have to look under the microscope to know what they are. But are they seen shedded epithelial cells? Probably.
Okay, fair enough. That's good to know. So you've mentioned the immune cells that are resident in the bladder, in the urinary tract. Are some people's immune systems just inherently stronger or weaker than others? And could that explain why some people are more susceptible to recurrent UTI than others?
Um, I mean, this is something that we've got to work out, but that would be the hypothesis, right? And even between male, female differences. So we know that there are very distinct differences in other organs and systems between males and females, and we know that the immune system behaves differently, even in healthy individuals,
Hmm.
just by based on sex, so whether you're male or female. And this could be driven by male sex hormones, but also just, the way in which the immune system is sort of set up. And of course, that makes evolutionary sense as well. Women are, childbearing, men aren't, and so our immune systems need to be,
Hmm.
geared a little differently for those sorts of reasons. And so there's some logic behind that. So indeed, there's some rationale there. I mean, look, there could well be genetic causes underlying this. There could be factors from early life that affect
Hmm.
this. There was a study that just came out earlier this week about a virus called BK virus, which is a virus that I actually have that's reactivated because of my immunosuppression with kidney
Hmm.
transplant. Now, about 95% of us will get this infection early in life. And then this virus sort of embeds itself in the urinary tract, in the urinary bladder, and in the
Okay.
kidneys. And then it can become reactivated in some people because of immunosuppression or
Hmm.
other illness or whatever the case might be. And then this virus is now sort of seen as a predictor for bladder cancer. But
Okay.
one of the things that I was thinking about is, okay, well, perhaps just these sort of viruses that we all have and hanging around as a result of early childhood infections that we all have, what's the consequence of those sort of infections that we think are benign in different individuals? Are they kind of
Yeah.
changing the landscape of the immune response in the background? Have you had lots of illnesses when you're young that changed how you set up? And we know again from respiratory disease that if you have lots of respiratory infections when you're very young, you're much more likely to get diseases like asthma and
Hmm.
COPD. So emphysema, for example, which we normally think is because of smokers, but even in non-smokers, these early life infections are a massive consequence for
Hmm.
decline in lung function in later life. And so it could also be that some of these early life challenges that we've had changes the landscape of our urinary bladder, both the immune system and structural cells, so that over time we become more susceptible to infections. And so perhaps these are the individuals that then go on to have
Hmm.
these recurrent infections. I mean, look, there is never-ending interesting questions for us to pursue.
Yeah, it
But
seems
there's a
that
whole
way.
bunch of things that could be going on there. But the short answer is yes, there could well be differences, and there probably are. But what's causing that could be any number of things, and again requires, a lot of investment for us to understand.
And all of these questions don't point to it being the patient's fault in any way. It's not about how they wipe or any of their hygiene habits. It's just things that we don't understand yet. And I think it's really good to highlight those.
Yeah, I totally agree with that. I mean, even with things like hydration, one of the things I really want to look at if we can get the funding for it, people say, you increase hydration and, you dilute out the bacteria. It's an assumption. Nothing's actually been
Hmm.
shown. I
Yeah.
mean, I would actually think that, hydration is changing the way in which the host, the bladder, is responding and
Hmm.
not just by diluting out the bacteria, but I would imagine that you're changing the way that the structural cells behave, the signals that they send to immune cells, and then what your immune cells are actually doing. So I
Hmm.
wouldn't be surprised if something as simple as hydration is actually changing the immune response. And we see that in the gastrointestinal tract, for example. Time of feeding is really important. So, relative to your circadian rhythm. So we eat at times of the day. If we sort of disrupt that and travel and eat at weird times of the
Hmm.
day, our gut will start to produce an inflammatory response from our immune system that it wouldn't normally do, which can then
Right.
cause damage to the gastrointestinal tract. So same sort of thing with drinking. It's got to be causing some kind of physiological and immunological response. So
Hmm.
often there's a lot of assumption with UTI,
There
Melissa. Like
really
people
is.
think, oh, we just do this or do that, has to
Yeah.
be that, but none of it's actually really been
Hmm.
proven. So I wouldn't be surprised if something as simple as increase in hydration is actually having an effect on us, the host, not just diluting the bug. So we really need to just understand what we're doing. But 100%, it's not our fault. I get really angry when people say it's because of your anatomical setup or you're
Yeah,
unhygienic. Because I mean, everybody that suffers from this condition knows it's not true. Every time I teach this to undergrads, all the female students are just horrified to think that people are being treated this way.
it is
It just
horrifying.
makes no sense. Yep.
Yeah, and a lot of things that end up being researched end up being things that patients have been saying all the time. Even the
Mhm.
hydration thing, a lot of patients say when they drink, their symptoms are relieved before it even gets to the point where they might urinate again. So there could be something else going on, but that's just put down to the assumption that it's in their head, that it's psychological, that it makes them feel better. And there's so many things like that, but we don't really understand the mechanisms.
But this is where we need to work with patients as well. And this is the power of consumer involvement in
Mm-hmm.
research. And in Australia, that's a really critical component of our research design now, because by understanding the things that patients are experiencing and what's the priorities to them, it can actually help us develop scientific questions and
Yep.
also to develop processes and approaches that best meet the need of the community. And I must say that Chronic UTI Australia and others and the initiatives that you're driving, Melissa, is really great in this space because it helps to educate us
Mm-hmm.
as scientists who I like to think, this next generation is very open-minded. We want to know these things so that we can try to, look at how that information fits into what we're seeing scientifically. So we need to do it in collaboration. We shouldn't be treating them as separate baskets. It shouldn't be
Definitely.
patients over here, medical doctors over here, scientists over here. We need to bring everyone together to talk about these things and their experiences and increase everybody's understanding to really drive innovation.
So, back on the immunotherapy side of things, can you explain in patient-friendly terms what type 2 immunity is and why these immune cells might be important for preventing chronic UTI?
Sure. So type 2 immunity is just a way that we label a particular arm of the immune system, so our host immune response. Type 2 immunity evolved to deal with worms, so helminth infections.
Mm-hmm.
And so really it's an arm of the immune system that's there to fight off worms. Now, we also know that this type 2 immune response is really important in things like driving allergy and asthma. And so it does also drive, when it's dysregulated, diseases that are pathologic, right? Like asthma. And so in the urinary bladder, what's happened is this type 2 immune response has evolved to, as we talked about before, repair the urinary bladder.
Mm-hmm.
But as a consequence, it's potentially you know, at the consequence of not having effective antibacterial immunity or immune memory. Now, we don't even think it's necessarily that simple, and we've just
Mm-hmm.
got new major funding from the Australian government to explore type 2 immunity and
Great.
UTI. And so we think that, and we've talked about this before, Melissa, so there's sex differences. So we know that there's large sex differences in type 2 immunity between males and females, with females having much stronger type 2 immune responses than males,
Mm-hmm.
with testosterone suppressing these type 2 immune responses. And so we think it could also be a biological reason as to why women are more susceptible. And we're also discovering some really interesting things, not just about what type 2 immunity is doing in immune cells, but also what type 2 immunity is doing within structural cells within the bladder lining.
Mm-hmm.
And so these are non-typical processes that we understand as scientists. And so we're really interested to understand what's happening in the urinary bladder because generally the urinary bladder gets ignored. If you look at studies where they say they've looked at multiple organs, it's never the urinary bladder. They'll look at the lung and the eye and the brain and the gut and maybe the kidney, but the
Yes,
urinary
I've
bladder is
noticed.
never, ever, 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 ever part of that
Mm-hmm.
process. And so the urinary bladder potentially has very different types of responses, or it's
Mm-hmm.
evolved to use these responses in different ways because it's a different organ. It's an exit organ. It's still exposed to the external environment. As we talked about before, it has to protect against these toxic chemicals
Mm-hmm.
within the urine. It's the waste product, right? It's the garbage truck of our body, right? And so the immune response there has to kind of balance all these different things. So we're
Mm-hmm.
trying to understand what that is. But our overall goal and hypothesis is that there's dysregulated type 2 immunity that we can then target with immunotherapies.
Hmm.
And we think that this is very achievable because there's already type 2 immunotherapies that are available for asthma. So our
Okay.
key idea is to repurpose the existing immunotherapies that have already been developed and already gone through clinical trial for asthma and
Hmm.
to repurpose them after having the evidence that we need to show that they're important, to repurpose those drugs for these recurrent or chronic urinary tract infections.
And what kind of advantages would immunotherapy have over antibiotics?
Well, exactly what we're just talking about, right? So, all the way through, we've been talking about this bug drug dogma. So,
Hmm.
antibiotics focus on targeting the bug, but immunotherapies target on restoring balance in the host response.
Hmm.
And when you think about it, we know that healthy individuals that see the bug don't really get unwell. So, it's not the bug necessarily that's the problem, it's the way that we respond to the bug that's the
Hmm.
problem. So if we always focus on the bug, we're sort of forgetting that part of us that's really the responder, right? So really what immunotherapy does is try to restore back to baseline, back to normality, back to homeostasis, so that we no longer respond to those bacteria the way that we were in the past. Now that's advantageous because we've always evolved with bacteria over millennia, right?
Hmm.
But we only evolve slowly. So getting us back to normal is important, whereas the bugs can evolve very, 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 very quickly. So no matter what we do, they're always going to evolve resistance to antibiotics.
Right.
And these bugs are so clever, they can even switch off their cell wall so that when there's antibiotics present, so the antibiotics can't kill them. And then when your antibiotics course finishes, they'll turn back on their cell wall again so they can go back on and infect. So
Hmm.
the bugs are that smart. They can evolve that quickly. We can't. We take millennia and millennia and
Yeah.
millennia to evolve these new mechanisms. And so I think by targeting the host response, we can kind of hopefully allow us to get back to a point where it's a bit more of an even playing field and our bodies have a chance of defending itself against these infections without having to rely on antibiotics. And of course, that's also important for antimicrobial stewardship, which is one of the issues that patients would face when they see their clinicians, is because clinicians are really worried about
Hmm.
antibiotic use and these antibiotics not being available for really severe life-threatening infections. And many people see UTI as one of the major causes of antibiotic prescription. And
Right.
so, if we have a way of being able to complement that therapy so we can reduce the antibiotic load in patients so that we can restore the host response, but we're also being responsible with the antibiotics that we have, I think it's a win-win scenario in that sense.
So one of the grants that you have is for your work on therapeutic targeting of cytokines for complicated urinary tract infection. Can you talk about how that might impact the patient experience in the future?
Yeah, so it's similar to what I was just describing with type 2 immunity. So
Hmm.
the other grant is really a similar sort of thing. In this case, rather than something being up and us wanting to use inhibitors to bring it back down, this was something that was missing that we need to restore.
Hmm.
So immunotherapy isn't just about inhibiting something. When we think about drugs or therapies, we normally think about trying to get rid of something that's bad. Sometimes it's also replacing something that's potentially good that's missing. And
Hmm.
so what we found here was that there was a particular immune protein that following infection doesn't seem to be there. And again, in females, this is lower compared to males, so it's
Hmm.
missing. And it's one of these things that you can replace. And of course, again, similar sort of strategy. Other companies have developed this immunoreplacement therapy for other conditions. In this case, it was really for psoriasis, so a skin
Hmm.
type condition. And so, again, these drugs can be repurposed to try to restore balance in the immune system. So, again, this personalized medicine comes in. So, for some individuals, they might be lacking this factor and we need to restore it. For others, they might have very strong dysregulation of this factor, so we need to inhibit it. For
Hmm.
other people, they might need that combined with antibiotics. So, I don't think it's just going to be a new magic therapy that's going to solve it for everyone. I
Yeah.
think we really do need to understand what's happening in each individual patient and then have multiple weapons in our armory to be able to deal with each of these different scenarios.
Do we already have the tools to investigate what's going on in each patient in that way so that we can tailor these drugs to their experience?
Do we have the tools? Yes. Have we proven how to do that in these patients? No. So the
Okay.
technology's there. We just need the urgency. So if you
Mm-hmm.
imagine a hypothetical scenario where we had a uropathogen that caused the kind of worldwide spread disease that COVID did,
Yeah.
we would have a solution to all of these problems in 6 months.
Yeah.
It just comes down to simply investment and awareness. And because COVID was perceived internationally by all governments to be
Mm-hmm.
such a significant problem, huge amount of investment, breaking down of all the regulatory red tape and all the collaborative barriers, everybody could just jump on this, and we had great solutions, which, happened very, very, very quickly. We would say exactly the same thing if we saw a life-threatening, highly resistant strain of uropathogenic bacteria that spread around everyone around the world.
Mm-hmm.
We'd see the same response. So do we have the tools and the technology? 100%. Do we have other technology that we didn't know about? Like most of the community didn't know about mRNA technology. That's been there for 30 years.
Yeah.
It's just we were able to take advantage of that technology when the time was right. So is the technology there? 100%. Is the capability there? 100%. But do we know what we need to be looking for? No, because there hasn't been the investment in being able to understand what this looks like in patients. And that's where we need to lobby governments, increase
Mm-hmm.
funding, and be able to work together collaboratively to really work out what these would be.
What do you think a realistic timeline is for this type of therapy to become available for patients?
I mean, look, people always, these things always take minimum 10, 15 years,
Mm-hmm.
in the normal pipeline, right? And that's when you have something really hit. The problem is that are you going to be able to convince pharmaceutical companies that there's a market here to make money? Because if you're being realistic about these things, pharmaceutical companies want drugs that they can give people for a very long period of time.
Yeah.
There isn't much investment from pharma in new antibiotics. It's not something that they're particularly interested in.
Yeah.
GSK's just come out with a new antibiotic, which is now being tested for UTI, which is great,
Yeah.
gentamicin, and that could buy us some time, and it could also create a new treatment option. But ultimately, the bacteria will find a way of becoming resistant to this. It's a very different type of antibiotic. It works in a very different way. It's a new class, which
Yeah.
is great. But that's one of the first new antibiotics for UTI in decades, right? So it's not like there's investment even in antimicrobials. So there is investment in immunotherapies, hence why we're thinking about how can we repurpose them? Because
Mm-hmm.
companies are going to be very interested in repurposing and
Yeah.
reusing drugs they're already making if they can make more money. But if they have to
Exactly.
create a whole new drug and if they have to spend $2 billion to develop a whole new drug for a disease that they don't see as marketable,
Mm-hmm.
then we're not going to get very far. So that's why we're taking the approach of, and we're being realistic of what can we do, what's important,
Mm-hmm.
what do we need to solve? And we know patients need new diagnostics and we need new non-antibiotic treatments. So as a group, we're going after it from the perspective of what's the immune system doing? And
Mm-hmm.
then when we look at that, what makes sense? What could actually have an impact? And then what's available that we can repurpose? Because unfortunately, there's too many people that just don't see UTI as a problem in the community. So business people and pharma aren't going to want to invest in what they don't see as a problem. But
Yeah.
if we can say, hey, you can reuse your drugs that you've already got and you can have this impact on quality of life, we have a chance. So in that sense, if we can prove these things, then prove it in humans, we could fit within that, 5 to 10 year time frame. But if we had to start something from scratch, I mean, I doubt we would see it in our lifetime, to be honest, just simply because of the investment pipeline and the
Yeah.
way that those things work. Yeah.
I mean, it's hard to feel hopeful as a patient sometimes knowing that these things are going to take so long. Do you think there are changes in the nearer future that might come into clinical practice in testing or in treatment options for patients with recurrent UTI?
I think we are in a unique circumstance here. Unlike things like cancer immunotherapy, there's a bit more urgency. You've got people with stage 4 cancer and they're
Mm-hmm.
out of hope. Ethically, there's more opportunity to do things there than there are with people that are otherwise deemed healthy, for a trial in these sorts of things. So it's a lot harder to get these sorts of therapies into clinical trial. So it's challenging. Melissa, I think we know we have to get so much inertia. Like this has been textbook after textbook for generation after
Mm,
generation. You know, you think about a medical training section, you know, you've got the consultant, the
hmm.
registrar, you know, the interns and, you know, and residents and things. And, you know, there's even the senior consultants are, you know, urine is sterile, you know, UTI is not a
Yep.
serious problem, you know, and then that filters down and they go to uni, they see the same thing, you know,
Hmm.
in their community, in their colleges and their guidelines, it's all reinforced. We're talking about changing generations of set dogma. You know, that requires very, very, very strong evidence. Whereas when you've got something like life-threatening cancers where there's just no option, people are a lot more open to trialing things.
Yeah.
Whereas in this scenario, it's a very different circumstance. So that can be frustrating for patients and for researchers and for invested clinicians,
Yeah.
but it's the reality of what we're up against. Like to change these guidelines is a big thing. And even to change diagnostic laboratories' thought
Mm,
processes and guidelines is a big thing. Like they really want to see evidence. And that's hard again if we don't have investment. But we are working here in Australia with Chronic UTI Australia,
hmm.
and we've got clinicians, and we're talking to the head of, you know, the clinical pathology board to be able to see if we can implement some of this understanding and at least, you know, not exclude tests and, you know, work through those sorts of processes. And, you know, hopefully be able to do things like that that can have more of an immediate effect. But, you know, it's frustrating. It's taboo. It's downstairs. It's women's health. It gets
Hmm.
ignored. It's terrible, right? But
Yeah.
there's lots of us that are fighting hard and advocating for this. And we do have some momentum now with politicians in Australia. And when you start talking to them, you realize a lot of people are affected by this experience too. They
Yeah.
just
It's a
don't talk
huge
about it.
problem. Yeah,
But now we get
exactly.
them talking about it, it really, you know, changes that. So we need champions, you know, we need politicians, we need famous
Hmm.
people that suffer from these conditions to come forward and make it something that we can talk about. And then, you know,
Yeah.
from there we can really create change.
And I think, like we've been talking about, we need to work together. And it'd be great to hear how researchers and patients can learn more about your work and maybe get in touch. And perhaps you could tell us a bit about the Bladder and Kidney Health Symposium, because there might be people interested in attending the next one.
Sure. So yeah, really, you know, I created the Bladder and Kidney Health Discovery Program really to break down these entrenched silos, you know, because disciplines and scientists and clinicians tend to sort of do things in
Mm,
their own little worlds. And I realized we're now in a world of technology and communication where we just don't have to do that anymore. And our collective brain trust and all of our different experiences and all of our different insights collectively can drive far better and faster innovation and change for patients. And so the whole concept of that was to break down those barriers, bring together people from infectious disease, microbiology, immunology, urology, nephrology, all these different disciplines and far more patients, you know, into a collaborative network. And so through that network, we're doing funding opportunities and collaboration, student exchange. But yeah, one of the signature programs is the Bladder and Kidney Health Discovery Program, which we run every year, normally in October, November.
hmm.
It's nearly always based in Melbourne, and we bring international experts from overseas. So this year we had Indira visit,
Hmm.
and we have you know, interstate speakers and commercial partners, patients, patient advocacy groups, you know, everything from undergraduate students right through to consultant
That's great.
clinicians, senior scientists. So really sort of bringing everybody together to talk about UTI is always a big theme, but
Hmm.
also other bladder and kidney conditions and sharing that knowledge and expertise to really sort of bring together the best minds to impact change.
Yeah, sounds really great. If you can share the link to that, I can put it in the video description so people can find out more and maybe get some
Sure,
attendees for next year.
sure.
It's been so good to hear more about your research, and I'm really excited to see what you're working on in this space. I do think it will have an impact on patient outcomes in the future, and that's really what we want to hear. So, thank you again for taking the time to share your research with us.
Absolute pleasure. Thank you for talking to me. And yeah, we're really passionate about this space, and we really hope that at least, you know, before I retire, we have some really meaningful changes. And certainly from our perspective here in Australia, we'll be pushing that as hard as we can. So thanks again for your time. It's been an absolute pleasure, and I wish you all the best with this initiative moving forward.
Thanks so much for watching. I hope you found this expert video helpful. If you'd like to learn more about this or related topics, be sure to check out our other videos or head over to liveutifree.com for related articles. We'll drop some links in the video description. If you like what we're doing on this channel, you can support our work by hitting subscribe here on YouTube, and don't forget to tick the bell so you'll be notified of our future videos. Thanks again for watching, and until next time, keep asking questions and pushing for better solutions.